Hello everyone. Warm greetings from Narayana Health Bangalore. I am Dr. Tanuj from Department of Obstetrics and Gynecology, and today we will be discussing the most commonly questions which are asked about gestational diabetes mellitus, or most commonly known as diabetes in pregnancy. For the same, we are honored to have Dr. Kranti Khadilkar for us, who is a consultant at Department of Endocrinology in Narayana Health Bangalore, and she will be busting some myths about the disease, and she'll be discussing the most commonly asked questions which are most of our viewers might have. So now we will be going towards the questions. So ma'am, like the most common question that the people have is, what is gestational diabetes mellitus and how it is different from the diabetes in the non-pregnant patients?
So, gestational diabetes mellitus in common terminology is diabetes which is first detected in pregnancy,
Yes,
or it could be diabetes which is first developed in pregnancy. So, certain point of differences between the two which will come in the later questions. Difference between the two is when you have a pregnant patient who is diabetic, you need to think about the baby also. So you need to have cutoffs which are quite stricter as compared to the routine diabetes population. Say for example, we are okay with a 140 or a 180 after meals in routine diabetic patients. But in pregnant ladies, we need to have all before meals close to less than 90, and sugar which is after meals, 2 hours after meals, less than 120. So very stricter controls, that is one. Another important thing is majority of the medications, oral medications, cannot be given in a pregnant diabetic woman. So we need to give insulin. So these are the two major factors which are different when you are diabetic and you are pregnant.
Yes, ma'am. So ma'am, like who are at risk of developing gestational diabetes mellitus in pregnancy? Can we identify those women?
Yes, we definitely can identify. People who maybe have PCOD at the outset before getting pregnant, people on the overweight side, higher BMI, those who have family history of diabetes, who had previous gestational diabetes in previous pregnancies, these are some of the examples of high risk, or you can identify amongst yourselves also. If you have these risk factors, you need to be actually prepared before getting pregnant. So you need to check your sugars, have a pre-conception counseling as well as testing, so that we detect any diabetes which is underlying before getting pregnant. And almost all of the pregnant ladies are screened in first trimester with a random sugar and a HbA1c, and in the 7th month with a oral glucose tolerance test. Or in simple words, you challenge yourself with a glass of sugar and you check your blood sugars every hour for the next 2 hours. So these tests are done for every pregnant woman in India, especially because India is the diabetes capital. So these are the risk factors which can point towards gestational diabetes or a risk of developing gestational diabetes. Dr. Tanuj here has done a study which we can discuss in some other talk, wherein we saw the waist circumferences and in the first trimestral ultrasound the degree of abdominal fat, and correlation was made with the risk of developing gestational diabetes. Tanuj, you would like to say something about it?
Yes, ma'am. So in the study, like I would just go for the conclusion part. So in the study, we just found out that the patients who had a subcutaneous fat thickness more than 3.75 centimeter, the visceral fat thickness of more than 5 centimeter, and who had grade 1 fatty liver. Along with that, we had taken several other parameters, like we had taken BMI and we had taken the waist circumference, we had taken the neck circumference. So those who had come onto the higher range, like basically to keep it in simple words, like in the obese category, those people were more prone to develop gestational diabetes mellitus. And it is just not the obese people, even the lean people. We found out that the lean people who had history of PCOD and who have been on treatment for PCOS and who had a higher visceral fat thickness and subcutaneous fat thickness, they were also prone to develop gestational diabetes mellitus.
So bottom line is, if you are in first trimester and you're getting your scan and the sonographer tells you that that, oh, your abdominal fat is a bit on the higher side, or you have a fatty liver, you need to be careful about what you take during the pregnancy. You need not eat extra like it is thought of, that when you get pregnant you need to eat for 2 people. It's not like that anymore. It depends on your baseline BMI. If the baseline BMI is normal or overweight, the weight gain during pregnancy should be not more than 10 kg. So there are certain criteria, but if a person is overweight or obese, as low as 7 kg weight gain should be there in pregnancy.
Yes,
the lower the weight gain and the slower the weight gain, that will help you in preventing the degree of diabetes which you developed in the 7th month. So even when you are in the first trimester, you can still control the weight gain and your diet and be active if it is allowed from the gynecology point of view. That would prevent diabetes mellitus coming in the 7th month.
Yes, ma'am. Ma'am, so like you have already answered this question, but how can we like diagnose gestational diabetes mellitus in the pregnancy? What are the specific tests that we do?
Yeah. So the typical or classical gestational diabetes is atemporary diabetes, which develops in the 7th month of pregnancy and it disappears after delivery. This is the classic type. There are other types where the patient is diabetic but she doesn't know and she gets pregnant and incidentally she has a sugar which is on the higher side. So the typical gestational diabetes is diagnosed with a oral glucose tolerance test. Either there is a 1-hour glucose challenge test which can be done anytime. You just walk in, you are given a glass of a typical measured quantity of glucose and 1 hour sugar checking is done and a cutoff is discussed. So probably above even 130 or 140 is a higher range, and then you go for the 75 gram oral glucose tolerance test, which is a fasting sample. You take a 75 gram glucose challenge and then 1 hour and 2 hour samples, and cutoffs are strictly followed. So even if one value is above the cutoff, you are labeled as gestational diabetes. So you tend to diagnose it more often so that you prevent problems in the pregnancy as well as in the postpartum period.
Yes, ma'am. Ma'am, like most of the people would want to know that how can gestational diabetes mellitus affect the mother and the baby during the course of the pregnancy?
Yeah. So the important point is when you are pregnant, there is a direct link with the baby. So what happens is if you are diabetic, there is high blood sugar. So that blood sugar gets transported to the baby like the food which gets transported through the placenta. Unfortunately, insulin cannot cross the placenta. So the baby starts producing its own insulin. So the problems in the baby are if the diabetes develops in the later half of pregnancy and it is not controlled, the babies tend to be bigger in size. So a chubby baby may not be always a healthy baby. So overweight babies can go into obstructive labor. They can have shoulder dystocia, injuries during deliveries, more chances of instrumental deliveries like C-sections, and they also get into more ICU stays after birth. So they get into hypoglycemia, sometimes unfortunately intrauterine fetal demise or death. So it is very important that we control our sugars to prevent these problems. In the mother, generally there is higher chances of getting into a seizure, sometimes like a preeclampsia which can come in, and more instrumental deliveries. So more forceps, more injuries to the mother as well as C-sections. So this is a major issue where we want to control sugar is for the baby rather than the mother. Another important point which we can discuss here is people who are diabetic who don't know. So if you have high sugars at the time of conception, or if you are diabetic and not on treatment, uncontrolled 3-month average sugar beyond 7 or 7.5, in the initial time of pregnancy when the organs are forming for the baby, high sugars can give rise to a lot of structural defects, cardiac defects or heart defects or other body defects, more chances of miscarriage. So 2 points. First, if you are diagnosed with diabetes in pregnancy, maintain your sugars very, very strictly. And if you are diabetic or you think you have risk factors for diabetes, check your sugars before you get pregnant. So a planned pregnancy would always help by seeing your HbA1c. So it is basically a blood test which measures a 3-month average sugar. If it is below 6.5, the risk for the baby for structural abnormalities is almost as equivalent as the normal pregnant lady. So these 2 points need to be kept in mind for all those who are planning pregnancy or already pregnant.
Yes, ma'am. Ma'am, so like once the patient is diagnosed with GDM, what are the treatment modalities that are available to keep the sugars in control in these patients?
So we have discussed quite a lot of complications and quite a lot of grievous scenarios. Now let us talk some positive aspects. So there need not be any panic if you are diagnosed with diabetes either in the first trimester or in the third trimester. Do consult your gynecologist and get in touch with a diabetes specialist, a specialist who deals with pregnancy and diabetes, so endocrinologist, and they will make you measure your sugars at home on the glucometer. So we get multiple readings and multiple readings after meals and before meals. So this is the way you first, don't panic, get in touch with proper experts, a dietitian who will make sure that you eat adequate calories, but the calories come from good foods or good glycemic index foods. So you don't tend to binge on more calories, but you don't tend to starve yourself also. In pregnancy, calorie deficiency is not going to help in controlling the diabetes. So diet in pregnancy and diabetes would be getting calories out of good quality carbohydrates and maybe smaller meals, multiple small meals. So starvation is not going to give you good readings of sugars. It will actually harm the baby. So a balance between the caloric intake, sugars, the weight of the baby on the ultrasound needs to be managed by a team effort of dietitians, endocrinologists and obstetricians.
Yes, ma'am. Ma'am, so the medications that we prescribe during the pregnancy, are this safe for both the mother and the baby?
Yes. So most of the diabetic medications need to be stopped or need to be avoided in pregnancy. The only oral medication which is permitted is metformin, which we all know a lot of trade names for it. But metformin is a basic medication even given for PCOD, for regularizing the cycles and for weight loss. So that is allowed in pregnancy. So it is completely safe for the mother as well as the baby. If the sugars are not controlled with diet as well as metformin, then we have to add on an injectable therapy, which is insulin. So insulin is a hormone generally produced by our body, but there is some deficiency or extra requirement in pregnancy in certain patients. There we need to inject either a single injection or sometimes multiple injections based on the sugars. It is an extremely easy injection. We will train you how to take the insulin on your own, how to measure your sugar, how to adjust the insulin. So there is definitely no need to panic. And with this team effort and medications, most of the deliveries happen without complications.
Yes, ma'am. Ma'am, so in future, what is, if the mother develops gestational diabetes mellitus, so what is going to be the implication of this disease in future, both on the mother and the baby?
Yes, this is important. So gestational diabetes is like a challenge to your body.
Yes.
So if you are one of the people who are developing gestational diabetes, you have high chances of developing permanent type 2 diabetes after you deliver. So if there is no improvement in the diet or lifestyle, at the end of 1 year, almost 50% of the gestational diabetes mothers can go on to progress into type 2 diabetes requiring medications. So if you are having gestational diabetes after delivery, after convalescence is over, do tend to get into good lifestyle measures, daily exercises, diet, reduce the caloric intake, especially of added sugars in your diet, and do check your sugars at least 3 monthly even after delivery, so that we can stop the progression or at least catch the progression at an early age.
Yes, ma'am. Ma'am, so when now every day, every time to the gynecologist, the patients will come for preconceptional counseling. So what can we tell them for the preconceptional counseling purpose, so that they are more aware that there is a risk?
So at the preconceptional counseling, maybe we should talk about the BMI of the patient. If they are on the overweight side, maybe gently tell them to have good lifestyle in place, diet in place, try to lose some amount of weight, get into some fitness regime, which will definitely reduce the chances of developing GDM. People who get detected with diabetes in the preconceptional counseling can wait for the conception till the HbA1c or the sugars are under control. So this will avoid the congenital anomalies which can happen if your sugars are high at the time of conception. Even for the male partner, Though they may not directly affect the baby, the sperm count can definitely get affected if there is uncontrolled diabetes in the male partner. So that also needs to be discussed in preconception counseling. And PCOD patients, especially as gynecologists, you can maybe give special attention to PCOD patients, check their sugars often so as to detect the diabetes at the preconception counseling or in the first trimester. Like we discussed, the abdominal fat,
Yes,
fatty liver, increased waist circumference, acanthosis, a darkening of the skin folds in the axilla as well as the neck. These are some of the soft markers which can tell us which patient will develop gestational diabetes. And then through the counseling which occurs at every obstetric visit, you as obstetricians can talk to them about how much they have gained weight in every visit, how is their dietary pattern. These can be some of the preventive measures which can be put in place before the patient actually develops gestational diabetes.
Yes, ma'am. Ma'am, so any special advice you want to give to our viewers, like who are having GDM during the pregnancy?
Yes.
Or,
GDM is not a problem. It is definitely something which you need to be aware of. You can try to prevent it, like we discussed, with a good lifestyle management in place before getting pregnant. And if you develop gestational diabetes, do take it seriously. You need to be under the care of a team of dietitians, endocrinologists, and obstetrician. And if the sugars are controlled well during the pregnancy, the outcomes are definitely positive, and there is then nothing to worry about.
Yes, ma'am. Ma'am, thank you so much for this informative session. I'm sure our viewers would have benefited from this whole session. Thank you all for watching.
Thank you so much.